Hello and welcome to the Anesthesia and Analgesia and Open Anesthesia's Article of the Month podcast. My name is Christine Park from Open Anesthesia's editorial board. The article for May 2017 is Anesthesiologists and Disaster Medicine, a needs assessment for education and training and reported willingness to respond. Our guest today is the article's lead author, Dr. Heather Hyunga, the Assistant Professor of Anesthesiology at the University of Pittsburgh. Welcome, Dr. Hyunga.
Thank you, Dr. Park, and thank you, Open Anesthesia and Anesthesia and Analgesia, for this wonderful opportunity to talk about disaster preparedness.
So I wondered if we could start by sharing with us the provenance of this study. How did the subject come to you and your co-author's attention, and why is it important?
Quite honestly, Dr. Park, as a first-year medical student, I did not really understand the American Medical Association's representation. I knew only that I received a nice complimentary dissection kit for my enrollment. I decided to find out, and in doing so, I attended a regional meeting in Columbus, Ohio. The keynote speaker at the meeting was to be my future boss, and his lecture focused on disaster medicine. Disaster medicine seems to disproportionately affect the underserved, and this intrigued me as serving the underserved was of paramount importance in my decision to pursue medicine. This also led to my desire to pursue further education in public health and disaster preparedness. Now, specifically regarding this paper, a growing body of research dating back to at least the early 1990s has examined the willingness, as opposed to the ability, of health workers to sign up for duty in disasters and public health emergencies. This research has uncovered striking gaps in scenario-based willingness among public health and hospital providers. Given the vital roles that anesthesiologists play in disaster response, the focus on anesthesiologists is timely and salient in the face of an ever-broadening array of emergent health threats. Our findings buttress prior research that highlight the gaps in response willingness among frontline health responder groups that poses a serious threat to surge capacity and health security in such contexts.
It's striking to me that you just said that the underserved are disproportionately affected in natural disasters. Can you explore that a bit further?
The underserved, if you think about disasters, may be disproportionately affected because of the existing infrastructure of cities and of towns. And if you think about disaster response is just one segment of disaster preparedness. Disaster preparedness actually includes disaster planning as well as disaster recovery. And you can see if disaster planning does not take into consideration the infrastructure, for example, then the underserved may be disproportionately affected. Similarly, after the response itself, it's plausible that in the disaster recovery period, the underserved may be forgotten or lost.
So as you write, the American Medical Association has outlined physicians' obligations to participate in public health-related activities. Not only that, the Associations of American Medical Colleges encourage training programs to incorporate disaster medicine into formal curricula. And finally, the Accreditation Council for Graduate Medical Education has developed guidelines about resident physicians' role in disasters. Could you please summarize what these recommendations entail?
Yes. The American Medical Association's principles of medical ethics state that a physician shall recognize a responsibility to participate in activities contributing to the improvement of the community and the betterment of public health. In 1950, in response to World War II, the AMA's Council on Medical Education developed a committee on medical education in time of national emergency. This committee concluded the curriculum of medical study should be reorganized to give proper emphasis to subjects of particular importance for the national health, security, and welfare in time of national emergency. In 2003, the Association of American Medical Colleges then developed a report encouraging incorporation of weapons of mass destruction related learning objectives into the existing curriculum across all 4 years of medical school. The Accreditation Council for Graduate Medical Education has then outlined that in times of disaster, residents are considered to be physicians as well as trainees. The organization advises that decisions regarding a resident's involvement in disasters must take into account certain areas. These include, number one, the multiple roles a resident plays as a trainee, a physician, and an institutional employee. Number two, the nature of the healthcare and clinical work that a resident will be expected to deliver. Number three, the resident's level of training. Number four, resident safety. Number five, the reasonable expectation for duration of engagement in a disaster. And number six, any self-limitations to act under significant stress or even duress.
In your paper, you state that every U.S. hospital is expected to have an emergency operations plan in compliance with the Joint Commission Emergency Management Standards. I'm curious, to what degree do anesthesiology departments participate in the development of these plans? Or what was the role of the anesthesiology department in your own institution?
Dr. Park, this is a complex question without a well-defined answer. I would prefer to say that anesthesiology departments are integrally involved in the development of emergency management plans, and I think that is necessary. With emphasis on the perioperative surgical home, combined with the fact that anesthesiologists are involved in many facets throughout the hospital, room to the operating room, to chronic pain management, to intensive care, this should be a pillar of our profession. I hope one day in the future it may be. We should look beyond the individual clinical encounter and be advocates for public health throughout the hospital, from the emergency room to the operating room, to chronic pain management, to intensive care. This should be a pillar of our profession.
The three institutions participating in this study were Johns Hopkins, the University of Oklahoma, and the University of Washington in Seattle. How do you anticipate the results might have differed if the surveyed institutions were in cities, for example, New Orleans, that have experienced major natural disasters?
Although the results of the study may not be generalizable to all anesthesiologists, regardless of hospital type or all geographic regions domestically or internationally, we purposely selected academic institutions in 3 different geographic regions. One affected by hurricanes and floods and located on the East Coast, Baltimore. One that may be potentially affected by earthquakes located in the Pacific Northwest, Seattle. And one potentially affected by tornadoes in the south central United States, Oklahoma City. Indeed, the Oklahoma City bombing provides a backdrop of experience in disaster management for Oklahoma City constituents.
So let's move on to talk a little bit more in depth about the study. Tell us, how did you develop the survey that was used?
The survey instruments used in this research were developed based on previous surveys that focused on the extended parallel process model. The extended parallel process model was designed in the 1990s by Professor Kim Whitty, a professor in communications at Michigan State University. The framework helps to predict how individuals may react when confronted with fear-inducing stimuli. The model has since been applied to workers' behaviors in deciding whether to report to duty when a risk may exist by examination of the interplay between perceptions of threat and of one's perceived efficacy in response.
For this study, how was the concept of natural disasters defined?
Natural disasters were not specifically defined in the survey instruments themselves, but would include such events as floods, hurricanes, earthquakes, and tornadoes.
So what about terrorist attacks as part of disaster medicine? This was not included in your study. Can you talk to us about why not?
3 representative disaster scenarios, natural disaster, pandemic influenza, and a radiological event were the focus of the survey instruments. We attempted to include terrorist attacks by asking about radiological events, or dirty bomb explosions as they're otherwise referred to at times. Terrorist attacks are designed to invoke fear, and this is indeed what a dirty bomb explosion serves to do. Interestingly, fewer respondents believed that they would be able to perform their duties successfully and that performing their role would make a significant difference in the success of the response to a radiological event compared with the other 2 scenarios. They also perceived that they had less education and training and were consistently also less likely to be willing to respond. Interestingly, though, the most significant contributor to physical injury or mortality related to a radiological event is the blast itself, not the radiological exposure. The purpose is to invoke fear and uncertainty. A dirty bomb is a conventional explosive with radiological materials. For most people directly involved, it has actually been estimated that the lifetime health risk is thought to be comparable to smoking 5 packets of cigarettes. This demonstrates the importance of disaster medicine education.
So let's continue to talk about the results of your study. Can you give us the rest of the highlights of your findings?
Yes, sure. Major results of this study are threefold. Number one, anesthesiology attendings and residents feel that their hospital or residency program, respectively, provides them with inadequate preparation and training to the 3 disaster scenarios surveyed in the study, but the majority of both cohorts believe that they should be provided with the appropriate preparation and training. Number two, despite this finding, the overwhelming majority of anesthesiology attendings and residents indicate a strong willingness to respond to natural disasters and pandemic influenza. Notably, fewer were willing to respond to a radiological event, although 63% of attendings and 54% of residents still stated that they would respond. And number three, interestingly, both attendings and residents were willing to respond in whatever capacity needed, not specifically to provide anesthesia.
What do other specialties provide for emergency disaster training, especially a specialty like emergency medicine?
Once again, this is a complex issue as no specific standards are in existence. A study published in 2009 by Masterson et al. Found that approximately 50% of emergency medicine faculty and residents reported a lack of disaster training, 50%. And this is astounding if the emergency department becomes the gateway to the hospital in a disaster situation.
That's very interesting. And on a related note, what data are available regarding willingness to respond to similar events in other specialties?
In a recent study in 2010 that specifically examined hospital-based providers' willingness to respond to an influenza pandemic involving 3,500 employees at a major hospital, 1/3 of whom were health professionals, one in four hospital workers indicated they were not willing to respond to an influenza pandemic. Hospital employees with a perception of high efficacy, as we discussed earlier, had 6 times higher declared rates of willingness to respond. These results are staggering when you take into consideration the number of people in different professions and specialties who work in tandem to successfully care for a patient. Think of all those who are involved, for example, in successfully getting a patient through an operation, from stocking the room to cleaning the supplies to performing the procedure, so on and so forth. In a separate study of medical students' willingness to respond to disasters, the majority of medical students were willing to respond. Similar to previous results, fewer were willing to respond to a radiological event compared to the other 2 scenarios. The issue, though, in both the medical student study and our study, this study, is that respondents did not feel that they understood their role or to whom they would report to during a disaster.
So it's very interesting to consider why those people who report that they're not willing to respond are not willing. Do you have any information to suggest why this might be?
There are multiple proposed reasons and thoughts as to why people may be unwilling to respond. One in particular, for example, is if someone does not have a family plan. If they do not have child care, for example, they may be less likely to respond if there is a disaster. Other particular issues that arise include whether or not someone knows how to get to work using an alternative route. This may also keep someone from responding to a disaster. In our particular study, we tried to tease this out a little bit more by asking about willingness to respond in different capacities. We asked about willingness to respond to one's hospital or residency program's hospital versus responding domestically, for example. Asked about international response. people had various answers depending on the questions that were asked. But overall, I would say that the large majority of anesthesiologists and anesthesiology residents were willing to respond, regardless of severity.
Dr. Hyanga, you refer to work by Paul Slovic, who has done extensive investigation into risk and how perceptions of risk, in contrast to an analytic approach to risk, affects human decision-making. So what do we know about the risks compared to perceived risks for healthcare providers in disaster medicine?
Paul Slovic's research focuses on axes of risk perception, describing how, for example, radiological exposure is simultaneously attached to both high threat perception and low observability. What he means by low observability is that a radiological event exposure is intangible and imperceptible to the senses, and this is fear-invoking. What we know about the actual risks depends on the scenario. What we do know is that steps such as donning personal protective equipment, ensuring family preparedness plans, as I discussed, understanding disaster mechanisms such as the pathophysiological pathways of bioterrorism agents, and furthering education so that our understanding of perceived risk best mimics actual risk, all may potentially serve to lessen any risks associated with caring for those involved in disasters.
Thank you. And now for one of my favorite questions, which is, what surprises did you encounter while conducting the study?
Actually, one major surprise that we encountered and were happy to have encountered was a uniform response by the majority of respondents, both anesthesiologists and residents, that 1 hour every quarter should be dedicated to disaster preparedness education and training. This quantification of perceived appropriate time in our perhaps already overextended schedule of topics for medical education and for residency education and for continued medical education will hopefully help those developing curricula to feel comfortable noting that this may be an appropriate starting point, and that's exciting.
And finally, what do you propose the next step should be for training anesthesiologists in disaster medicine?
Based on the conclusions of our study, next steps would ideally be the incorporation of disaster medicine education and training into all anesthesiology residency curricula and anesthesiologists continuing medical education. Coupled with the aforementioned study on medical student willingness to respond, this study has further identified a gap between physicians and trainees' perceptions of their disaster preparedness education and training and their desire to be educated and trained. And this may indeed influence willingness to respond and plausibly effectiveness in doing so. Therefore, a national standardization of disaster medicine education should be developed in medical schools, residency programs, and continued medical education curricula, not only to foster willingness to respond and increase knowledge among future and current anesthesiologists, but also to plausibly expand to other medical professions by setting a precedent of importance of physician preparedness for disasters.
Well, thank you very much. This has been Anesthesia and Analgesia and Open Anesthesia's Article of the Month for May 2017. Our guest today was Dr. Heather Hyanga. Thank you very much for being with us today.
Thank you, Dr. Park.